Hello, everyone, and welcome to our Alaska Collaborative on Health and the Environment teleconference on a holistic approach to public health, addressing toxic exposures, environmental justice, and intergenerational trauma with Lynn Freedman. Thank you for joining us this morning or this afternoon for some of you in person. Even though we record these teleconferences and they're available as podcasts in the future, there's a lot of value in having you on the line live. And I want to remind you that there will be an opportunity towards the end of the call for your questions and comments on this important topic. My name is Diana DeFazio, and on behalf of Alaska Community Action on Toxics, I'll be facilitating today's call. CHE Alaska is a regional partnership group of the National Collaborative on Health and the Environment. CHE Alaska aims to advance knowledge and effective action to address growing concerns about the links between human health and environmental factors. You can find more information at akaction.org and healthandenvironment.org. Alaska Community Action on Toxics staff heard Dr. Freedman speak at the Indigenous Women's Reproductive Health and Human Rights Conference at Columbia University last April, and they were impressed and moved by her work to transform the way public health care is done. At their suggestion, I reached out to Professor Freedman, and we are delighted that she agreed to be our speaker today. She has a few presentation slides that she will be referring to during her talk, but this is not a presentation per se. So she may refer to them here and there, but you don't need to strictly follow along. She'll be sure to call your attention to the page number of the PDF when she is referencing it. I just sent a link to you this morning, so please check your email and download the document now if you haven't already done so. It's only 11 pages long. You can also find a link on our website at akaction.org. And again, during the last 10 minutes of the call, we will invite participants to ask questions or make comments. Now it's my pleasure to welcome and introduce our speaker for today. Lynn Freedman is a professor of population and family health at Columbia University Medical Center, and she currently directs the Mailman School of Public Health Averting Maternal Death and Disability program, a global program of research, policy analysis, and technical support that since 1999 has worked with UN agencies, NGOs, and governments in more than 50 countries in Asia, Africa, and Latin America to reduce maternal mortality. Before joining the faculty at Columbia University in 1990, Professor Freedman worked as a practicing attorney in New York City. Professor Freedman has published widely on issues of maternal mortality and on health and human rights, with a particular focus on gender and women's reproductive health. She also serves on the advisory boards of maternal health projects and human rights projects with programs in Asia, Sub-Saharan Africa, and Latin America. Welcome, Lynn. You may go ahead and begin.
Great. Well, thank you very much. Good morning and good afternoon to everyone on the phone. Let me begin by thanking the Alaska Community Action on Toxics for this opportunity to connect with all of you. And I hope at the end, certainly I have a chance to do some important learning from you as well. I want to particularly thank Diana DeFazio, who has been in touch with me over the last few months to organize this call, and to Pamela Miller and Vi Wagii at the Alaska Community Action on Toxics, who, as Diana said, were at a panel on Indigenous women's health and environmental toxic exposures, where I had the opportunity to speak and to address the question of collaborations in order to document and halt environmental violence. So let me actually begin at the end and tell you what my ultimate point of this talk will be, and then kind of work backwards toward that. So the ultimate point that I want to make in this talk is that in addition to whatever rigorous quantitative studies are needed to generate data to prove detrimental health impacts from toxic exposures, and I know that's the bread and butter of litigations and certain kinds of advocacy. As important as that is, and I agree it's incredibly important, I want to suggest for discussion that there's also the need to be thinking about long-term, deep, community-driven partnerships that generate all kinds of data and evidence, and not just the kind that we need in a litigation, in order to create a much more complex and nuanced picture of toxic exposures and what they mean for certainly Indigenous communities and the people who are part of them, in a way that really can bring power to those communities on their own terms, that can build on their own assets and strengths as a community, and ultimately challenge the structures that are responsible for poor health and for the failure to meet basic human rights. And this is a different approach to public health from perhaps the kind that those of you who are on the phone who are public health people might have learned in public health school. But I see this kind of public health work, including certain kinds of research that I'll talk about, as social action in itself. And so I come to this really myself as a lawyer, a human rights lawyer, a practicing lawyer who then trained in public health. And I've spent a career trying to develop the connections between human rights and health, and to really build what globally we call a rights-based approach to health, and particular to the work that I've done in maternal mortality. So one of the interesting things about maternal mortality and other parts of public health as a human rights issue, it is not just about stop the violation. You know, a classic human rights violation like torture is about just stop the torture. But when we build a human rights-based approach to health, we need to talk not only about stop violations, but also about positive fulfillment of rights, about providing services, but services in a way that, you know, truly honor people's lived experience. And in our work, that's largely about the lived experience around reproduction and parenthood. So it's not just a clinical issue, it's very deeply a social and political issue. And as a rights-based approach, I have to say that over the last 20 years that I've been working on this, we really have had to build the ship while sailing, so to speak. We've been trying to address this issue as a human rights issue and create a new way or a different way of doing public health, shall we say. Most of our work has really been in South Asia and Sub-Saharan Africa, because that's where maternal mortality is really concentrated. But in the last few years, we've actually turned to the U.S., which is one of only 3 countries in the entire world that has an increasing maternal mortality rate. Every other country in the world, it's dropping and dropped. The U.S., which is ranked 46th in all countries in the world in maternal mortality, which of course is nothing to brag about, is the only country where it's increasing. And so in the last few years, I think it's been really important for us as a human rights public health group to turn our attention inward and look in the U.S. And you know, I think that's given us some insights that may be relevant to the work that all of you do on environmental health and toxic exposures. Here at the Mailman School of Public Health at Columbia University, we actually have a new program called Global Health Justice and Governance that's explicitly trying to focus on gender justice, environmental justice, and food justice, and to bring those three together to uncover their roots and to generate new data and evidence in order to work with collaborators to build, again, a new kind of movement. So I'm really honored to have this chance to engage with all of you today. I need to confess here at the start that I've done very little work on environmental health per se as a public health issue. I am certainly not an expert on toxic exposures or on environmental law or even on intergenerational trauma, and I know some of you on the phone probably are the country's leading experts. But I think those who invited me to give this talk thought that introducing our way of thinking about health and rights would spark some conversation and ideas among those of you who have really devoted a lifetime to living and working with environmental justice issues and in Indigenous communities that struggle with toxic exposures. So even though this is an environmental health group, I am not going to pretend to teach anything about toxic exposure per se, but rather to put forward an approach to public health that we've used in maternal mortality, and hope that at the end we can talk in some ways, and I will make some comments about the specific issues related to environmental health, but I want to just put the qualification early on that that's not what my expertise is. But anyway, let me start by laying out some principles that are part of what we call a rights-based approach to public health. So I'm just going to address a few principles, put them out there, and hope we can build them back up together to come up to an approach to public health. So the first one is understanding that public health, that is not medicine, but patterns of health in populations, are deeply rooted in broader historical, social, and political dynamics. So that's just fundamental truth in public health. So public health phenomena, therefore, often have geographic and also physical environmental dimensions that requires us to be sensitive to the dynamics of problems over time and space. So that's the first one, deeply rooted in these broader social and historical dynamics. The second, which I actually put in a piece of paper just for emphasis, is slide 2. That while health is always entails biological and physiological dimensions, no question, it is always also political. I would say if you scratch the surface of any public health problem, choose any one, if you scratch the surface deep enough, it is always also about access to and distribution of power and resources. Understanding that, we recognize that change in public health will never just be about doing the right study and putting the data out there. It is always also about building a social and political movement for change. So when we think about everything we do, even when it's deeply technical and data oriented, we are conscious that change in health and the causes of patterns in health are always political. On slide 3 and then 4, I also want to make this what I think is a really crucial point that's often missing in our public health discussions and our health discussions, that health systems themselves, healthcare, are not just mechanical delivery systems for delivering clinical interventions, the way a post office delivers a letter. But rather, we have to understand health systems, hospitals, clinics, health workers, all of health insurance, all of the ways health systems work, as being part of the very fabric of social and civic life. And so just like an education system or a justice system or a police system is a social institution, so a health system functions as a core social institution that reflects priorities of the state, values of the state and the society. And I think that's deeply true in the U.S., as our current politics show. But on slide 4, I make the further point that neglect, abuse, and marginalization by the health system is part of the very experience of what it means to be poor in the world today. So I think we have to not think about poverty as just deficit, not having money, not having food, not having adequate shelter. It's also about your interactions with structures of power. And one of those is the health system. So the marginalization that people experience in the health system is part of the experience of being poor. But the converse is also true, that effective health claims are, the ability to make a claim for care and have it met is really an asset of citizenship and a democratic society. And so when we talk about try to look at people's access to health care, either in response to things like environmental contamination and the health effects that we can document, that's really a big part of the power dynamics of public health. And whether we address health systems as social institutions or not, people experience it that way. And that's the key thing, because we need to understand health systems, and health interventions from the perspective of the people whose health is at stake. And that leads me to my next principle, which is that knowledge in public health has to be co-created with the directly affected communities. And their lived experience needs to be given close, meaningful attention in understanding problems. I would tell you this is very present in my work today, because just this week, I'm working on the results of a study about disrespect and abuse that women experience in maternal and childbirth care. And I have to say, the very same issues that women see as deeply disrespectful of them and their parenthood, providers see as sometimes essential good quality care. And it's not a question, I'm not looking at the question of what's the right, clinical intervention to do, but the fact that people experience the health system as deeply disrespectful, and that matters. So our knowledge of that needs to be generated, co-created with directly affected communities. And last principle is, I think we are committed to what in the public health literature is called consequential public health. That data has to be used for social change and for challenging power. If public health ultimately is about access to and distribution of power and resources, then our data and our research needs to be designed to challenge that. It has to be for people, not just academics, to lead in that process. So we're not interested in just a linear translation where we as academics generate data and deliver it to communities and think that's the end of our obligation. I think we're really talking about co-creation. And there are a few different methodologies for doing this. I'm just going to mention two key ones, and we'll be happy to come back at the end to talk about them if they are, something that people on the phone want to pursue further. So one is the methodology of community-based participatory research. I'm sure some of you on the phone are very experienced practitioners of that. I think it's a strong and growing practice in public health, but it's amazing how rarely it's done and how rarely it's done well. The second that is less strong but now growing is really borrowed from the tech world, and that is human-centered design. So increasingly in our work and in public health, we also take data and research, and we don't just come up with what seems in theory to be a great intervention and maybe this will work. Let's just pilot it and measure the results. Rather, interventions, efforts to address public health are done through design principles using human-centered design. So these two things, CBPR, community-based participatory research, and human-centered design, both understand that people are at the core of health and healthcare, not just finding the right technology, and that it has to be delivered in a way that meets people where they are, that builds them up, not beats them down. And that's kind of at the core of what a rights-based approach to health has meant for us. So if you were all sitting in the room, I would pause here, but I gather I'm supposed and ask for questions, but I gather I'm supposed to continue on. So as a lawyer working in public health, let me say that as we've become more and more successful at turning maternal mortality into a human rights issue and not just a medical issue, and it's now very recognized in human rights law as a human rights issue, we've had to start dealing in countries around the world with lawyers and litigation. And as a former litigator, I have to say this is kind of a mixed blessing. So, clearly litigation has been hugely important in environmental justice, and I'm sure many of you on the call are involved in that. But I want to really acknowledge and point out and be conscious about an emerging tension between the litigators' or legislators' approach to understanding the nature of this public health problem and the one that I'm advocating. So in litigation or legislation, liability and responsibility are built around proof of impact and causality. And we have one set of methodologies. Well, we have multiple sets of certain kinds of methodologies are appropriate for doing that, for generating that evidence of impact and causality. But we need to acknowledge that by definition, that kind of research is simplifying truth, because that kind of research, totally appropriately for what it's trying to do, is trying to understand isolated risk factors like a toxic exposure and measure their probability and their attributable impact. And I recognize that doing that increasingly is essential for litigation and legal change. But I think in public health practice, the trend is moving in the exact opposite direction. Instead of trying to isolate risk factors and simplify, we are trying, in fact, to complicate our understanding, not beyond the reality, but to have a more complex understanding of chains of causality and the interactions between historical, social, political, and clinical factors. Because historically, at least in my own specific field, maternal mortality, we've clearly been too focused on clinical causes and medical interventions. They're absolutely essential, as is the relief from certain toxic exposures. But separate from the legal actions around these things, we're really trying to build a rights-based approach that speaks in new ways to the complexity of people's lived reality of these exposures. So I want to give you an example of some recent work that we've been doing on racial disparities in maternal mortality, and talk about how that might be analogous to some of what we know about toxic exposures and intergenerational trauma. So I just want to point you to slide 5, which is a graph about that shows the maternal mortality ratio, MMR's maternal mortality ratio, the number of maternal deaths per 100,000 live births in New York City by race. New York City and the U.S. by race. And what you'll see is huge disparities. In New York City, it's been shocking for people here to acknowledge, to recognize that Black non-Hispanic women have 12 times higher mortality than white women in New York City. For the country as a whole, it's Black women have 4 times higher maternal mortality than white women. And some of you may be aware that this has gotten a huge amount of publicity. You know, I say huge amount. I may have selection bias, and I see every article that's written, so I don't know whether most of the country is really catching it. But on slide 6, you'll see a few recent examples. The New York Times magazine, which of course is read all around the country, had this recent article which asked exactly the right question. Why are Black mothers and babies in the U.S. dying at more than double the rate, for mothers 4 times, for babies twice, as white mothers and babies? And they say here right on the cover that the answer has everything to do with the lived experience of being a Black woman in America. This for many in the country, perhaps this became true, came to consciousness when Serena Williams, the tennis player, had a recent pregnancy where she had a life-threatening complication that the doctors ignored her when she said what it was wrong with her and demanded that she have an MRI. And this has become a very important story in the community working on this, because obviously this is a person with power and resources, except that she's also a Black woman, and felt very clearly that she was not being listened to. So one of the points I want to make here is that we are no longer talking about race as a demographic risk factor, right? As a demographic factor. we are talking about racism. We are trying to understand and acknowledge the importance of structural racism as a social, historical, and political phenomenon, and try to understand how that gets under the skin, how that actually affects the physiologic health of people. And I think I'm not belaboring all of the data or putting all of the data out there, but I think there's a pretty good consensus around the so-called weathering hypothesis that shows that toxic stress from structural racism actually has physiological effects that a lifetime of discrimination or trauma build up over a lifetime of living as a Black woman in a racist society actually has an effect on mortality. And we see in New York City, there's data, and it's replicated elsewhere in the world, that a Black woman, this is not mediated totally by education, a Black woman with a college education has a higher chance of dying than a white woman without a high school education. So race and structural racism plays a really important role in the disparities we see, and actually in the death of women. So I raise this because simple answers don't really answer the question of why a disparity, why there's this disparity or increasing risk of mortality. And similarly, simple solutions don't actually solve the question. And efforts to do just simple solutions, isolated risk factors, and just address a single risk factor ultimately generates frustration because it doesn't understand a complex problem. And so I want to raise this as a parallel to the question of toxic exposures and intergenerational trauma. And because of my field, raise maternal and infant mortality. So you'll see on slide 7, I borrowed some data from the Urban Indian Health Institute, and perhaps someone from that institute's on the line and knows much more about how this data was generated. But on this slide shows you on the left, in the urban areas where the UIHP has service areas around the country, and they're urban, the rural data may be much worse. But American Indian and Alaskan Native women have 4 times higher mortality than non-Hispanic white women in the same areas, and infants have double the infant mortality rate. So we see similar kinds of disparities to what Black women experience in this country. And while the historical, for Black women, the legacy of slavery is very real, and much of many aspects of obstetric care were developed in experimentation on Black women. And this is very much carried in, this legacy of racism, I think, is very much carried into, is very much understood as intergenerational trauma and carried into parenthood, including interaction with the health system as a social institution, which itself adds trauma very often to what is already existing as trauma. So while many of you on the phone, I'm sure, understand much more than I've learned in my own research about American Indian and Alaska Native historical experience of trauma, of racism, of stigmatization, of devaluing of parenthood. I mean, it may be a factually different story from Black women's story, but I think for Native communities, it is there's a parallel, and so I wanted to in slide 8, I've just copied one example of an effort, in this case, looking at chronic disease, to show the kind of ways in which historical trauma, including centuries-long genocide, as well as very specific things like the boarding school experiences, end up interacting with adverse childhood experiences and various governmental programs like WIC, Women and Infants. These are nutritional programs, and adult stressors. And this particular graph does not include toxic exposures, but I'm quite certain that if you could add toxic exposures to this, and it would, it'd be one more complexity in this picture. So I use this as a potential parallel to the kind of causality framework that would be part of a collaboration that began to develop a complex picture of what's happening. In slide 9, I add a reference, especially for the lawyers on the call, to a very important case that was decided in the Inter-American Court of Human Rights, which is one of the very few cases I know of, I think one of the very few out there, that actually looks very carefully at the right of people of an indigenous community to their ancestral property. I mean, here we're talking about access issues, but also degradation, environmental degradation. And so obviously toxic exposures not only harm people's lungs, for example, and their skin and their bodies, but it harms their land and their property. And this court rather eloquently, and I just copied one sentence here, there's actually quite a bit more in the opinion, about the way in which the court established and acknowledged the spirit, as this quote says, the spiritual and physical foundations of the identity of Indigenous peoples are based above all on their unique relationship to their lands. And the court goes on to talk about the requirement to acknowledge that unique relationship to land and the cosmology, the way of living, the way of being and seeing in the world, and to recognize, and here it was recognized legally, that the breaking of a community's relationship to their ancestral land, and I would say whether through ownership and access or through environmental degradation, actually creates a kind of vulnerability that we can link to specific health problems. And in this case, as lawyers on the call know, sometimes you have to bring a case around very specific cases and controversies. So here there was an individual Indigenous woman from this community who died in childbirth at age 38, and the facts of her childbirth experience and her subsequent death were described in the materials for the case, but the court acknowledged the complex causal chain from the deprivation of the right to ancestral property to the actual death of an individual woman. And the chain went through the community's relationship to its land. And I think that's the kind of relationship that you could do an epidemiological study, but you also have to do a kind of complex, community-driven public health study to understand the nature of that challenge. So I think one of the questions is how do we not turn a case like this Chakmakasek case into one more way of reinforcing trauma, actually, and of recharacterizing or stigmatizing Native people as only broken cultures, while we acknowledge the trauma that was described in the facts of this case. How do we engage in a public health process that acknowledges that, recognizes that, but does not equate the community with brokenness? How do we make it trauma-informed, but not totally trauma-identified, and also make space for communities themselves to lead a process of generating evidence, qualitative evidence, quantitative evidence, storytelling, anecdotal evidence, a complex picture of the many factors that we understand increasingly, including structural issues as Black women have done with structural racism, to create a new picture of the community. And so I kind of end with with reference in slides 10 and 11 to the emergence of a reproductive justice movement. So from a field that, first, if you look at slide 11, compares a reproductive health model, which is really about service delivery, crucial, important, but only a tiny portion of the story, or a reproductive rights model, which ultimately was a legally focused model, that really narrowed and isolated different issues, to a reproductive justice model, which is led by women of color, for the nation and in their own communities to generate an approach to their own health, their own rights, their link to other social movements, their ways of acknowledging trauma, devaluation, intergenerational trauma, but refusing to be broken by it, and to use their engagement as researchers and advocates and the partnerships they make and they lead to build a new picture of who they are, how they live in the world, and how they demand to be respected and honored. And so this is the approach to public health that we're trying to build. As I say, it's kind of build the ship while sailing. I think it's, in addition to everything else you do to document the effect of toxic exposures, this way of building your own picture of yourself and how you live in the world, I think is a huge part of what we need to do in public health if it is going to be the kind of impactful social movement that I really believe it can and must be. So let me end there and turn it back to Diana.
Thank you so much for your thought-provoking presentation, and I'm sure we have some folks out there who would like to ask questions or make comments. So now is the time we like to invite our participants to engage in the discussion. If you'd like to ask a question, please press *2 to to unmute your line, and please also state your name and affiliation. When you're finished, it's really helpful for you to press *2 again to mute your line so that we don't end up with excessive background noise. So again, press *2 to unmute your line.
Hello?
Hi.
This is David Dell from Cape Cod.
Hi.
I was wondering if our speaker could comment on using people's stories to convert into support of a program on environmental justice and for using environmental justice and reproductive justice to develop a program that meets local needs of impacted communities.
Sure. Did you say using people's stories?
Yes.
Yeah. Well, you know, I think people's stories are a complex part of this process and hugely important for advocacy, but those stories need to be owned by the people whose stories they are. And I think that sometimes both lawyers and public health people appropriate those stories and remake them in ways that can be deeply stigmatizing. And I think we as both lawyers and public health people have to both understand the power of a story for finding an end goal, but also understand the power of it for the person who owns it. And be very conscious of the ethical obligations we have when we tell those stories and see who tells those stories.
Thank you, Dave, for your question, and Lynn. Again, if you'd like to ask a question, please press *2 to unmute your line.
Hello, this is Peter Whitehouse.
Hi, Peter.
Hi, I'm an intergenerational neurologist from Cleveland, Ohio. And first, I love the presentation. My question relates to the great focus these days on brain health and the idea that even something that appears to be so medical as Alzheimer's disease, the area that I work in, is really so ripe for the kind of analysis that you've given, and that we should be, for example, connecting lead poisoning in youth with late life dementia. Would you comment on whether this very salient and visible area of discussion of health, brain aging, might fit into your framework?
Yeah, I mean, I think it absolutely does. And, you know, I think there's a great example of where the science of brain health it's just so related to the social, both the social dimensions for Alzheimer's patients, but I think also I'm trying to remember there's I'm sorry, I don't have it right at hand, but there's a very interesting piece of work from cognitive neuroscience about the way that power works in systems and how we can also use brain science to understand the workings of power in our communities. So I'm sorry, I'm not giving you, I don't have it right at my fingertips, but I've been very interested by it because it tells us that, you know, it's not just about lawyers' advocacy, even our efforts to understand how power dynamics in a society work could have a cognitive neuroscience basis.
Thank you. Although we also have to be careful about the power that we grant people that think they have an understanding of the brain that can be helpful, in my opinion. But thank you.
Yes, absolutely. And we have to be careful that any social thing doesn't turn into a strictly biologically determined answer. I mean, I think the whole point that you're making, and I very much appreciate it, is the interaction between the biological and the social. And Alzheimer's may be certainly aging is a critically important place for us to understand that.
Thank you both. We still have some time for questions and comments, so press *2 to unmute your line. Again, to those who've already asked questions, if you could just make sure to mute your line when you're done.
Hello, this is Jose Luis at the Minnesota Pollution Control Agency. And this is an amazing presentation, and something we're trying to do here with the environmental justice work we're doing is talking and highlighting sources of social toxins regarding overburdened environmental justice, overburdened communities around historical unemployment, broken immigration system, police brutality, food deserts, are aspects that we should lay over in looking at some of the point sources of pollution in these communities. So I'm really excited with this presentation. I just wanted to share that comment and what we're trying to do here in regards to permitting, air permitting facilities in overburdened communities.
Yeah, fantastic. I mean, I think it's really important. I know I have colleagues here who are epidemiologists who've worked on all these impacts of different toxins. But when we start working with communities and, even kids in the neighborhood where Columbia is here, and when they start doing some of the measurements and so on, then the whole complexion of the project changes. So I really, really appreciate what you're describing, and would be great to learn how the communities are engaging with that effort to build a complex picture in Minnesota.
Thank you. We're thrilled that so many people have called in from all across the country. I do want to take a moment to invite any Alaskans that may be on the line to ask a question.
Good morning.
Or make a comment.
Good morning. My name is Bai Warai. It's an honor to have you on this call, Lynn. We met last.
Are you? Yeah.
We met last spring at Columbia University at the Environmental Violence Symposium, and I would just like to thank you. And you just described my life. You just validated my life. And I come from a community where we have 2 former Air Force bases, but because of our reliance on our subsistence foods, we're also some of the most highly contaminated population on the planet. And this has resulted in health disparities never seen before in our people. And I share my story over and over, and nobody, when we talk about our own health concerns, we're still being discredited. And yet, also our healthcare system, it's very evident. You talked about how health systems neglect, abuse, and marginalize is part of the very experience of being poor. These are our communities in rural Alaska who have to, my community lives on an island and the hospital is on the mainland. And if they are properly diagnosed, they have to be sent to here in Anchorage. And it has never been adequate health care from the get-go. And yet the federal government has an obligation to give us the best health care possible, but we never see it. But I wanted to thank you. It's for having this discussion, and thank you.
Well, thank you too very much. I remember very well meeting you here in New York last year, and thank you for all that you do as well. I think there's so much we all in public health can learn from understanding the world through your eyes, and I think that's a big part of what we hope to do as we build long, strong, deep community partnerships, not episodic partnerships. And I hope that that's part of what you're able to do there as you build this picture of what's happening in your community. Thank you.
Thank you. Thank you, Vi.
Yeah, can you hear me? This is Leslie from Nashville, Tennessee.
Yes.
Great. I work for a small home performance company here in Nashville, and we're partnering with Vanderbilt University to start a study that looks at the indoor air quality and indoor living conditions of homes across Tennessee and their correlation to energy consumption. And we'd like to weave in the concept of public health, and I don't have any experience in that. And so I was wondering if there are any major references that I could use, or certain like ideas or references you made to these different categories, the different framework categories for reproductive health, if there was anything similar to that in terms of either energy consumption in homes and economic status, or indoor air quality and indoor environmental health and economic status.
Thank you very much for your question. I have some colleagues who work quite a bit on indoor air pollution, with whom we are speaking. There may be people on the line also who do this. So I personally don't know the answer to your question, but I'm very happy to have an email interaction with you and engage some of my colleagues who are helping to build our program on global health justice and governance, who focus on, many of them, on air pollution issues, including indoor air pollution in homes around the world, I mean, in many different countries. So I'm guessing that there is some good data on the social gradient of this issue and its impacts.
Thank you so much. I would greatly appreciate that. Thank you.
Sure.
Thank you. Lynn, would you like to make any closing remarks? We are pretty much out of time.
Well,
so I have to close the discussion portion.
Yeah. Well, thank you. Let me thank all of you for the opportunity. I'm very happy to be in touch online, and I hope that this conversation, if nothing else, just sparks other people to be also thinking in their own fields about these dimensions of public health and human rights. So thanks so much, and
thank you. And I'm sure that this conversation was inspiring to many people. And I want to invite folks to email me if you have further questions. My email is diana@akaction.org. You can also call our office at 907-222-7714. And if you have additional resources, this goes for you as well, Lynn, but to participants as well, that are on this topic that you'd like me to include in a follow-up email. I like to share what the people on the call know and on the topic. So I welcome you to send that. I would want that today because I'll be preparing the podcast to send out tomorrow. So thanks again to everyone for calling in today and for your thoughtful participation. Remember, this teleconference was recorded, and I'll send you an email when the podcast is available so you can listen again if you joined late or if you wish to share it with other people. So thanks again, and have a wonderful day.
Thank you.
Bye-bye.